Welcome again everyone. My today's lesson is about Wilms tumor or nephroblastoma. Wilms tumor, also known as nephroblastoma, is the most common primary malignant renal tumor of childhood, and it is the second most common malignant abdominal tumor in childhood after neuroblastoma. Wilms tumor accounts for 6% of pediatric malignancies and more than 95% of kidney tumor in childhood. Approximately 75% of cases occur in children less than 5 years of age, with a peak incidence at 2 to 3 years of age. Wilms tumor is thought to be derived from incompletely differentiated renal mesenchyme. It can arise in one or both kidney, and the incidence of bilateral Wilms tumor is around 7%. Most cases are sporadic, but approximately 2% of patients have a family history of nephroblastoma. Genes commonly associated with Wilms tumor include WT1, P53, and FWT1 and FWT2. Those genes are tumor suppressor genes, and their absence predispose for the development of nephroblastomas. Wilms tumor can occur as a part of rare syndromes, including with aniridia, genitourinary system abnormality, and intellectual disabilities. And also it can present as dense dry syndrome, which includes Wilms tumor, kidney disease, especially nephrotic syndrome, and ambiguous genitalia. And also Begwis-Woodman syndrome, which is an overgrowth syndrome characterized by macrosomia, large tongue or macroglossia, hypoglycemia, abdominal wall defects such as umbilical hernia or omphalocele, and the Wilms tumor might also present in Begwis-Woodman syndrome. When we see the clinical presentation of nephroblastoma, the most common clinical presentation for Wilms tumor is the incidental discovery of an asymptomatic abdominal mass during routine physical examination or by the mother herself during changing clothes or diapering a child. Hypertension is present in about 25% of cases, mainly due to increased renin activity, and abdominal pain, gross painless hematuria, constitutional symptoms such as fever, anorexia, weight loss are other findings at diagnosis. Sometimes rapid abdominal enlargement and anemia occur because of bleeding into the renal parenchyma or pelvis. Wilms tumor thrombus extends into the inferior vena cava in 4 to 10% of patients and rarely into the right atrium, and the dislodgement of the intravascular tumor may produce a fatal pulmonary embolism. Patients might also have microcytic anemia from iron deficiency or from anemia of chronic disease. Regarding diagnosis and the differential diagnosis of Wilms tumor, abdominal ultrasound is very important. It differentiates solid from cystic masses. And also on abdominal ultrasound, focal areas of necrosis or hemorrhage and hydronephrosis because of obstruction of the renal pelvis by the tumor might be seen. And abdominal ultrasound with Doppler imaging of renal veins and the inferior vena cava is useful to demonstrate tumor thrombus in the renal veins and inferior vena cava. CT is useful to define the extent of the disease, integrity of the contralateral kidney, and the metastasis. Chest CT is more sensitive than chest radiograph to screen for pulmonary metastasis, and it is preferably performed before surgery because effusions and atelectasis can confound the interpretation of postoperative imaging studies. A core needle biopsy obtained through posterior approach, just to limit the contamination of peritoneal cavity, should be performed in case of unusual presentation or unusual imaging finding, such as significant lymphadenopathy, or if there is no renal parenchyma seen, or if there is signs and symptoms that might show neuroblastoma, such as intratumoral calcification. Regarding treatment of Wilms tumor, early surgery provides accurate diagnosis and staging and can facilitate risk-adapted therapy. Preoperative chemotherapy can make surgery easier and reduce the risk of intraoperative tumor rupture and hemorrhage. Surgery entails a radical nephrectomy with meticulous dissection to avoid rupture of the tumor capsules and lymph node sampling despite the absence of abnormal nodes on preoperative imaging studies or intraoperative assessment. Partial nephrectomy is performed in patients with bilateral disease or those with unilateral Wilms tumor and predisposing syndromes such as Dench-Dry syndrome, Wager syndrome, and to minimize the risk of future renal failure. Prognostic factors for risk-adapted therapy include age, stage, and tumor weight, and also tumor histology. Absence of anaplasia is considered a favorable histologic finding, whereas presence of anaplasia is unfavorable histologic finding. Patients with favorable histology have a good outcome and are generally treated in the outpatient setting. Nephrectomy alone is sufficient for patients less than 2 years old with stage 1 disease and a tumor weight less than 550 grams, resulting in a 5-year event-free survival of 84% and a 5-year overall survival of 98%. Patients with stage 1 and stage 2 disease receive chemotherapy. Recurrent disease is common, approximately 50% of favorable histology and 50% of anaplastic histology Wilms tumor relapses. Most relapses occur early, within the first 2 years of diagnosis. And regarding prognosis, overall survival of children with Wilms tumor exceeds 90% with some prognostic factors such as low stage, favorable histology, young age, low tumor weight, and those things have a good prognosis. Wilms tumor tops the list of common pediatric solid tumors in terms of favorable outcome. This is all about the short summary of Wilms tumor. Thanks for listening.